seem to have a lot of food there, but
Yes, we can hear you.
okay, so the story is that this patient has had adenocarcinoma involving the area of the head of the pancreas and has had resection, a right hemicolectomy, as well as Whipple's procedure done in December. And then following that, he has been complaining of tummy pain, and a CT scan has shown some collection in the lesser sac. So I've yet to see the CT films myself, but while we are waiting it, we thought we'll put the scope in and see what we can find. So I think that's the area that they are, you know, sorry? Bugle, US bugle. So there's food in the, uh, in the stomach. So usually if you've got fluid in the lesser sac, you should see a lot of fluid here in this area. I'm not sure how old the CT scan was as well, because according to the CT report, it was inflammatory collection. So it may well be that the fluid is, so just from an EUS perspective, so we've got the aorta, the first vessel that coming off is it the celiac. We just there we can see the celiac axis coming off there. The celiac axis then will change into the splenic artery. Images, they are not very brilliant, but you can see certainly the splenic vein there and the PD, some changes in the pancreatic duct. So I'll just move towards the tail of it. So we've got the left kidney there and just moving towards the splenic hilum. So we can see that area. So the tail area, we've got the spleen, the splenic artery. We're going towards the body now. And that's the left kidney. Just going towards the neck and head area. So CT images are they? Okay, so they're going to just put the CT images on the screen. Is there endoscopic image लाइएगा? I just want to see how much food there is. Is endoscopic image लाइएगा, please? हाँ. Just want to see where we are. Yeah, thank you. So I've just advanced the scope slightly forward and just trying to see if there's any collection down there in that area. Obviously the anatomy has been changed. Suction on, no?
Yes.
Have we got the CT images yet? No, no, that's fine. It seems to be working. It seems to be doing the trick. So don't worry about that. So I'm just trying to find, because it was reported as a 10 centimeter large collection in the lesser sac. So I couldn't appreciate anything significant from the GOJ. I'm just trying to see if I can find it, further down. There is a lot of food debris there as well. But just going around, I'm just trying to see if there's any significant fluid collection. Can't seem to appreciate any there. I'll just see in the mid-stomach area if there is anything that we can. Not in that area as well. No. So can we have the EUS images again?
Yes.
Okay. So just to assess this area again, the lesser sac, we've got the pancreatic tissue up there, the splenic vein, splenic artery. we're just viewing it all the way to the splenic
Yeah,
and again.
Shazad,
Yeah,
that's very nicely shown. When you've had post Whipples or post surgical stomach,
yeah.
um, looking at the entrum or looking at the distal part or the head of the pancreas, anything you want to mention?
So I'm just trying to trace from here. I'm going now towards the neck of the pancreas here. So obviously you can see the pancreatic tissue just above the splenic vein and the splenic artery. And then at this point, obviously, where it dips down, this is probably the surgical margin here, I would have thought. But I can't actually appreciate the 10 centimeter collection that they have mentioned here on the CT.
So there are two issues. One, I think it depends on where it was done, and there's something there.
No, I think that's just the bowel.
That's
isn't
just
it?
the gut.
Yeah,
Okay.
yeah.
So this scan was done a little while ago, and it was done. I don't know where it was done. So it's quite possible
29 June.
that the fluid may have.
They did mention on the scan that it looks inflammatory, and they did mention that it's in the lesser sac. So the lesser sac area, I did have a look from the GOJ, and then I've just randomly tried to see, at various levels of the stomach whether I can appreciate, because if 10 centimeter fluid, we should be able to pick it
Yeah,
up.
Shazad, I think the fact that you're not seeing the fluid is probably because the scan was done a little while ago, and the patient that is probably resolved on its own.
I wasn't able to have a chat with the patient, so I'm not sure how symptomatic he is at the moment. He is having third cycle of chemotherapy for recurrence of his malignancy.
So this patient was referred to us only 2 days ago. Patient was symptomatic, has had Whipples and also in fact left Hemi, has been referred by the surgical department with this previous CT. So currently there doesn't seem to be a collection there.
Yep. Okay. Sorry, I'll just have a look at the CT scan, yeah?
Is there another room ready? Can we move to another room, please?
Keep on going, keep on going, keep on going, keep on going, keep on. ऊपर आए, हाँ ऊपर आए. ये तो bladder का area ना, ऊपर आए, ऊपर आए, ऊपर आए.
Khalid, Assalamu alaikum. We are with you.
Walaikum assalam. Okay. So I don't know if the case has been presented yet or no.
No.
Okay. So I can just give you a brief of that. This is a kitni age kitni inki? 32 years old, and जी? Okay. 32 years old, and he had a dysphagia, and overall manometry, everything is suggestive of type 1 achalasia. So type 1, type 2, type 3, there are 3 types as we know, and there are other dysmotility disorders. Type 1 and type 2, we usually, what we do in those is like, we can do a relatively shorter myotomy. We have a good evidence now, the longer and shorter, they both work pretty much same. But one thing you want to make sure is that there is no esophagitis, and so there's not much inflammation there. Because you have to get through the GE junction. If there is an inflammation, that would be that could cause a deeper injury to the mucosa and go into the deeper layer. So you don't want to be doing a patient which has a active esophagitis, basically, for multiple reasons. That's one of the reasons which I mentioned, and the other is like risk of infection and everything. So here, the esophagus is quite dilated actually. I did not expect it to be that dilated the way I was told, but it is quite dilated. And his GE junction is at 48 and yeah, 49, 48, 49. So I think I'm going to do a 8 centimeter tunnel in this. For that, if it's, I consider it 49, then we'll start at 42, 40, 41, 42. I will do an anterior approach, which is more at 1 o'clock. If I put a little bit fluid accumulates on the posterior wall because the patient is pretty much on the back. So here, I think we are at 40. We will start the tunnel in this area, entry point right there. From there, I'll extend the tunnel anteriorly, downwards, and all the way to couple of centimeter below the GE junction towards the cardia, and then we'll do the myotomy. So that would be the whole plan. This is good right here. Injection there though. I don't know. I start injection with the needle.
Okay.
And is that's what
Yeah, Farooq does the
did
same.
too?
Yeah,
Okay.
yes. You start with injection and then
yeah.
cut and then get into it.
Now, so, like there is a way to do even with the RB jet too. You can just put that directly on that, do a little bit cut, and but that's not. I think the proper way to use is. I'm starting at 41. Up, dekh rahi ho na, almost. Yeah. So needle into the patient. Okay. So go ahead and slowly start injecting. Inject slowly. हाँ जी, चलते जाओ, inject करते जाओ. Good. Keep चलते जाओ, चलते. So what I'll do is I will do a really good injection here because this is the entry point. I don't want to do a muscle trauma or muscle injury right at the entry site. So I'll do a like 3, 4, sometimes 5, 6, 10 ml, whichever. That's good enough. छोड़ दो. Needle out of the patient. So you see that's a nice lift there, nice injection there. And that's, I think this is a good injection. I'll take the needle out, use the knife. I will do a vertical incision on this. दे दो मुझे. Knife. Okay. I'm using a hybrid RB knife, which has a jet, which has an injection in there. ओपन करो ज़रा नाइफ को. Okay, ओपन करो ज़रा और ऊपर all the way. अभी okay. So this कैमरा नहीं है. कैमरा किधर है? कौन सा? अच्छा ये वाला. Sorry. तो अगर आप नाइफ को देखें, I don't know if you can even see that the knife when it is completely open is like almost 5 millimeter or so. So you want to be cognizant of that, like how long the knife is, and इसके जो cutting कर सकते हो? चलो. Okay. Yeah, light on कर दो. अरे ये knife पे ज़रा focus करो, कर सकते हो? ये just. I don't know if you can see that or not, but
yes, we can see it a little better now.
yeah, yeah. Needle, you can see the
focus
needle.
करेंगे तो नजर आ जाएगी. थोड़ा सा पीछे कर लो.
Focus करो.
Just go back a little bit. पीछे करें. हाँ, that's it. Perfect.
Okay. So the knife is like almost 5 millimeter long. So just keep that in mind how long the knife is. And knife को वापस कर लो. And you can do a like you don't have to push the whole knife out if you don't want to. But usually it ends up being out completely. So just keep in mind that how long that is because you don't want to cause a trauma. Other thing which you don't see right here under my feet is there is a like a scope washer, that paddle. There is a RB jet, the injection with the knife. That's called the jet. That's an injection with the knife. And then there is a cautery that paddle. What I do is I put the cautery paddle on the left, the both water jets on the right. You don't want to put everything on same side. The problem with that can happen is like if you want to do an injection and the knife is out deep into the submucosa, you're thinking you're pressing a jet paddle and instead you press a cautery paddle, and that was called trauma. So to avoid that, This way I don't have to keep looking at my those foot paddles. I put those on the two different sides. Chalo, knife de do. And what I'll do is I will do vertical incision in this. So what I'll do, I will find the area where I started the injection. If visible quickly, then I'll use the same entry point, yellow paddle, just one. काम नहीं कर रहा. So हो गया?
सर लीड यहाँ पे कनेक्टिंग आ रहे जा रहे थे ना लोग.
So the lead is not connected.
न्यूट्रल लीड.
Yeah, so that's why it didn't work. Let me know when ready. Okay. So this is the interior approach. That's what I explained earlier. What I'll do is, so anyway, here I'll use a yellow paddle, and you see that how it went in just with one tap. Now I will put a little bit pressure and move down, vertically down. You see that? And I see a submucosa inside. So we are good here. I'll do a little bit cautery there on the side. चले जाओ उसके ऊपर. Press the tunneling and myotomy one. Yep. हाँ बस. Okay. Okay. So I'll just trimming a little bit from inside, so I can create a space for me to be able to put that cap scope in. So here I'll push that knife a little bit in and inject. You see that injection? It's just up with the foot paddle. That's why I like the this RB net. इसको pull कर लो वापस थोड़ा knife को. Okay, good. I will see if I can get in with this. If not, then I can always create a more space and cut downward. So I think what I'll do is I will cut a little bit more, knife off. I will cut a little bit downward here, and that should be then enough for us. So the main thing is, I don't know, अब चले जाओ वापस myotomy पे. इसमें ये है कि you have to make sure that you keep pressing the button and go using the right settings of the cautery. And if you look here, I'm just pressing a little bit that paddle and just creating a space for me. So now I'm into the tunnel. You see the muscle on the front side. I will push this out a little bit more. So I will just keep extending my tunnel downwards. Okay, so pull back a little. So now we are right into the tunnel. Now what I'll do is I'll keep my muscle side on the top and my mucosal side at the bottom. You guys see clearly the distinction, correct?
Correct. We can see it very clearly.
Yeah. So those circular muscles, you see that how they are straight?
Yes.
And that's the orientation I will try to keep. Knife de do mujhe.
Khalid, the knife preferences and system preferences when you're doing poem?
So I usually start with the RB. Really, I like the RB for this. And even for G poems, I like RB knife because one of the major reasons for that is, like if I'm doing a ESD, my preference may be different. For that, I will use a dual J, and based on if it's in stomach or upper or stomach or esophagus or duodenum or colon. Colon, I'll use a 1.5, and in upper one, I'll use a 2 millimeter. But for poem, my preference is RB jet. You see that how I'm extending myself down there, and I honestly, I have done already half of my tunneling. Okay, so it shouldn't be. Hopefully, would not take too long. and we have not encountered any big vessel. I just want to make sure there's no vessel right here. I will inject. I think we're good right there.
So with the Irby, you're injecting with the same
Same knife.
yeah, same knife. So that's a big advantage, isn't it?
Yes. And you see that how nicely it's I'm staying away from my mucosal side. I'm facing towards the muscle, so even if I cause a muscle damage, I'm happy, no problem. And other thing is CO2, sorry I didn't, हमारा CO2 किधर है? इसको कम कर सकते हैं आप CO2 को? वो हाँ, pressure कम कर दो यार. हाँ, pressure कम कर दो. So once you, I failed to mention that, like once you get into the tunnel, then you can really decrease the pressure. So here, I think look at that, we are already have done quite a bit of tunnel. And if I go out, you look at the tunnel, it's very straight tunnel because I'm paying attention to the orientation. Okay, so we have done half of the tunnel. I'll go back into tunnel. Okay. I think we need to, I'm tilting a little bit towards the left side. So I'll open up from the right side now a little bit, but before that I'll inject this.
Khalid,
Ji.
we'll just move to Mustafa for a bit and then come back to you when you want us to come back and when you're done.
Yeah,
I
you
think
can
it'll
come
only
back
take
anytime.
Another 5 minutes, I think.
Yeah, well, hopefully you'll be in the stomach by then.
Okay. Mustafa, we are going to come to you.
Right wala 1 o'clock.
Farooq, you've taken the lesion out? Hello?
Know that. चले
That
बंद
went
करें.
too fast. Hello?
बंद करें. Close fire.
Yes, sir. Fine.
Farooq,
जी साथ भाई.
that was the duodenal net.
That was a duodenal net is gone, and I always clip duodenal lesions, whether they bleed or they do nothing. Always as a standard. Sorry, man, I didn't realize that we were going live.
No, you were not actually. We missed the removal.
So it was really just an EMR. We didn't even go for do it. The lesion was too small. It wasn't the worth.
Okay.
We're hopeful. मैं आपको lesion दिखा देता हूँ. We're hopeful the margins are clear. और one of the ways we do that is कि आप इसके ऊपर you can throw some methylene blue on it. वो lesion कहाँ है? आपका done हो गया.
फारूक आप देख लें उसको मैं we will just go to Mustafa.
Lovely. That's fine.
Fluoro 1 या 2 में होंगे यार.
I think the wide rim around this, I think it's all clear. मैं और केड़ा मरीज है?
बलून वाफिक को
Mustafa, we are with you.
Okay, can you see our, I don't think you can see our images though.
We can't see your images yet.
Fluoro, if they could show you the fluoro image, that'd be good.
There was a concern about ascites in this patient. Was that an issue?
We're going to find out. I've gone ahead
Pull back.
with the assumption of doing an EUSGJ. But once I put the scope, the EUS scope down, I'll let you know. Fluoro, but आप हमारे कमरे की fluoro उन्हें दिखा दे. नहीं नहीं. You need to see the fluoro right now.
Fluoro लगा दें, please. Yeah, we can see the fluoro now.
Okay, so we went, oftentimes how we do it is go down with a therapeutic scope, put a wire down and put a nasobiliary drain through the scope and back out the scope.
Okay.
But we didn't have a nasobiliary drain available right now, so the alternative that we used to do is put the wire down and then go with a stone extraction balloon over the wire. So that's the part we're about to do. So back tension. So we're just advancing the stone extraction balloon into the stomach. Back tension. Hopefully we will see this all picture.
Yeah, we can see it
Yeah, there.
coming and turning
Exactly.
into
And
the. Yeah, you can see it turning all the way.
so
Yeah.
the stricture is right at the pyloric channel, which is right about here. So just
It's where the clip is. It's a little above that.
yeah, and that clip was there before.
Yeah.
So now that's a Coley clip, I guess.
Wait, what is the advantage of putting a biliary drain versus this? What you're doing?
So it's a larger lumen, and so it's much faster filling of the jejunum.
Okay.
And secondly, you can do this whole process endoscopically under direct visualization. And then you just put the nasobiliary and you pull out the scope, so you're good to go. So it works really well actually. So now our balloon, I'm having a hard, okay there, I think it's spine ko cross kar raha hai. But we're deep enough because we're past this obstruction.
Yeah.
So we're going to leave that there. Now I'm going to go in with the EUS scope. So, but we tend not to start distending it at this stage because it induces peristalsis. So usually we start distending the bowel after the EUS scope is down.
So you inject once you've got the ES scope down.
Yes, so we may be a couple of minutes here actually. So if you want to
Okay, we can move back to Khalid. Khalid साहब के रूम में करते हैं Khalid साहब डॉक्टर Khalid.
हाँ जी, balloon के साथ. Exactly. हाँ, नहीं इसके थ्रू देना है और बलून अप करना पड़ेगा आपको. बलून इन्फ्लेट करके हाँ. दूसरा ये है कि कुछ देते हैं मोटिलिटी कम करने के लिए यहाँ पे.
Khalid, we are with you, Khalid.
नाम क्या? हाँ वो दिन होगा.
Khalid, हम आपके साथ हैं.
Can you hear me?
Yes, we can,
Okay.
and we can see it as well.
So you see the G junction right here?
Yes, we can see the
You
muscle
see
there
that
as
those
well.
all those spindle vessels? So we have completed the tunnel already.
Oh, that was awesome.
So I'm just extending into the fundus, and I'll show you that we are way beyond that the GE junction.
Actually, we can see it, Khalid.
So see it from outside. Look
Yeah.
at that straight tunnel,
Yeah.
straight tunnel. You see your blue color,
Yeah.
blue color. You
Yeah.
see that color, blue color, and we're into
gone
the
into
stomach.
the G.
Yeah. So now we'll just do a myotomy. So myotomy, I'll start like my entrance ends right here. I think this should be okay right here. So I'll just go ahead and knife dena zara.
Is there any precautions that you need to do different to when you're doing posterior?
No, not really. It's
No?
the same approach, and just posterior. One thing is the entry becomes a little bit easier with the posterior.
So why did you prefer anterior over posterior in this?
I majority of my patients I do anterior.
And what is the
Because that's how I trained.
Okay. But is there any difference in terms of results?
Yeah, I think there is not much difference honestly with the results. There is some minor evidence that anterior might have a less reflux.
Okay. Nice. Okay, there's a question. Is there a less risk of uh, mucosal damage when you're doing anterior, or is it the same?
No, it's same. जरा ड्राई कट देना मुझे. Ready? Okay, वापस चले जाओ. So yeah, that's a longitudinal outside. You see. So I don't know if you are noticing one thing. I'm hooking up a little bit muscle at the bottom and just pulling it up.
Khalid, we're seeing this done very masterly. Ready, we'll go there. This is almost done.
So this is a GE junction right here.
Yes, Khalid, we can see that.
So that is going to be a little bit, sometimes it bleeds in that area, which is okay. There was a vessel, I should have been a little bit more careful, but yeah, go ahead. Dry cut. If this doesn't work, we can always use a coag grasper, so that should be okay. Dry cut. I think we're okay. थोड़ा सा अभी ड्राई पे ही रखो. Okay, अब वापस चले जाओ. Ready? वापस हो ना मायटमी पे. So that was a GE junction. बस किस पे हो? ठीक है.
आप येलो पेडल यूज कर रहे हो?
हाँ जी, येलो पैडल. For my आर्ट में येलो पैडल. So you have to be a little careful at the GE junction. That's where the vessels are usually, and they could be a problematic. You can cut them.
That's a sling.
It's on the side, yeah.
Very nice.
Okay, dry पे जाओ जरा 1 मिनट के लिए. ये किधर है वैसे? यहाँ पे है. So if I
That's
have
the
a
advantage.
कहाँ पे है वैसे? यहाँ पे है. मेरे ख्याल हो गई है
बेटा वहाँ पे जरा चेक करना मुस्तफा
साद भाई
हाँ
we are almost done here
you're done
yeah I'm gonna cut this last fiber
Okay.
and then I'm gonna come back and close it
okay so we're going to go to Mustafa he's ready to actually
when-
do the Gastro-J
okay when he's ready to if you want to come back I'll start closing
yeah okay you let me know
वापस पे जाना।
if you want us to come back for a bit okay well done Khalid that was quick and very very impressive Mustafa we are with you
Okay, so this is the small intestine that we're distending. If I go counterclockwise, you can see fluoro as well or not? You need to see
no
fluoro.
we can't see fluoro
You need
So
to
we
see
don't
the
need to
fluoro.
see the room we don't
Yeah.
need to see the room we need fluoro and EUS yeah we've got EUS now we need to have fluoro we have two EUS images thank you we
ठीक
have
जा रहे
fluoro
हैं
now
नहीं?
ड्राइव पे जाओ जरा
Okay, it needs to get big. Okay, good. So you can see the EUS scope and you can see the balloon. This is the small intestine. If I go counterclockwise, you can actually see the inflated balloon right there. And if I show you on floor, I'm sitting on the balloon. The things to look out for, which
Put all the way down here cut that
one has to be careful. This is colon. You see this loop of valve underneath the probe right now is colonic air. And one just has to be careful not to misidentify colon as small intestine. Here we have balloon.
ठीक है
The only thing, I don't see a lot of ascites, but there's a bit of edema in the bowel which
okay clips
may suggest carcinomatosis, but
16 लगा दो
what I want to do is make sure that my small intestine is distended adequately. So we're just filling water contrast mix, and you can see some contrast on the fluoro image. But
can you show us the fluoro image इसको थोड़ा छोटा कर दें fluoro को तो maybe we'll see it a bit better
छोटा कर दें.
कैसे you see the balloon there you started filling up the system there so there's a question
Yes.
how much distance are you comfortable with what's the
Yeah,
maximum
that's always a tricky one. So you really ideally want it 10 or less. I feel that you can get away with more. So this is 11. I think a lot of the bowel will get compressed and be brought to the stomach.
so you said the bowel wall looks thickened doesn't it
Yeah.
are you going through the pancreas
No, that's mesentery.
that's mesentery
So, yeah, so pancreas, I have to pull back. This is pancreas.
okay yeah
So it's not uncommon to see mesentery. If you can find a window where you can get off the mesentery, that's good. Ironically, the balloon is right where that may be. So I may, but no, I think even there, but this is okay. I may just pull the balloon back a tiny bit just to see if that area distends. a
Fluoro?
bit. Fluoro is live.
okay
I'm just gently putting the balloon back. So this is where the nasobiliary drains are
much better
better because you get so much faster filling than the balloon.
okay so what I wanted to understand was when you've got the balloon inflated you're actually filling the segment distal to the balloon correct
That's what we're trying to do. Yeah.
yeah so the problem is that the fluid won't I mean how does the fluid stay in the small valve
Well, we flood it. There is in Japan they have a double balloon.
that's what I was thinking because I'd
Yeah.
seen that somewhere I couldn't remember but they have a device
They have
which-
a device.
yeah the way the catheter has balloon
Yeah.
and the filling is if you had a balloon which would fill you know, not distally but proximally, proximal, and then you could actually use that.
Yes. So this is something we like to see in this situation where you have bowel that is going in the trajectory of the stent. The stent's going to come out like this. So if my bowel is going, I can see lumen coming this way. That gives me a longer landing space for my stent to come through. Because if you go cross-sectionally, then you have less space to deploy the stent. But if you can have it angling to the left of the screen, this is what we look for. So now I'm getting more comfortable with this, but we're going to keep filling, and then in the meantime we're going to get the stent ready. So 15-10 axios मुझे चाहिए, और secondly over there we give glucagon, but whatever anti-motility agent
So
it's given. Okay.
You know, we should have glucagon, but we don't use it because of the cost. What we use is we give atropine.
Yeah, I think we just gave that.
1 cc diluted in 10 cc, 1 ampule, and then we just give 1 cc, and that works for us for most of the cases. We use that for ERC.
Stent, yeah.
मेरा सही है ये साथ दो मुझे
It's okay. So इसको गीला wet gauze के साथ.
So when you're selecting the stent size, the bigger is better?
Not necessarily. I think bigger is certainly available. Especially early on, I would suggest going with the 15, because the 20 is a bit stiffer, and deployment can be more challenging than a 15. So it just so happened that we had the 15 first, so our learning curve was on the 15. But and patients do just fine with the 15. But now that we have 20s, we go with 20s. There may be some data to suggest 20 is better, but most people will do just fine. So I'm gonna, once I'm in position, and I deploy, I won't go through the steps because it's a time-sensitive deployment. But just before we do that, I'm going to go through the steps. So here's the tip of the stent coming out. And we want we need to distend this more. So once we have a very nicely distended loop of bowel and we find our window, we can go for it. So this is, when you see me tenting like this, you can see that the actual distance is not going to be more than 10. If this is the tip,
we can see that.
Yeah, you can see that, right? So I'm just now going to look for, this is what I would love to be able to do it in. So just as a recap, the steps are, and I don't know if you can't see my handle, but step 1 is to, under cautery, advance the catheter into the bowel. Step 2 is you lock it and you deploy the distal flange. That's your most critical step. Then you can once you visualize it, you can then pull back on that distal flange from the small bowel and you can deploy your proximal flange. So right here I feel pretty good about this.
Okay, can you give us just a minute or so, because Khalid is done with his poem and he's just closing, so we'll just be with him for a minute and less than a minute and come back.
Yeah, sure.
Can we go to endo, please?
थोड़ा सा patient left. या बेड और इधर को कोई
Khalid?
बेड को थोड़ा सा देते ज़्यादा ठीक है.
Khalid sir, चले गए Wasim? Okay, so you're just showing please close the thing, it's all done. Okay, Khalid, we're just back with you for just to see. You've closed the thing and...
can you hear me?
Yeah, it took you 25 minutes.
Can you hear me?
Yes, we can hear you and we can see you.
Oh, okay. We already closed at 2.
Yeah, I know. You took about what, 25 minutes?
ठीक है हाँ मेरा आई थिंक वी आर डन ज़रा दिखा दो उनको वो देख रहे हैं आप इट्स प्रीटी ओपन इजीली गोइंग ऑल द वे
Yeah, we can see it well.
ओके
Khalid, as usual, you're unbelievable. Thank you.
थैंक यू ठीक है
Go back to Mustafa, please.
उतार लो उतार
Okay. So you can see.
Mustafa, we are back with you, but we don't have the visuals, but we should have them in a second.
Okay. I'll wait.
Just give us a second. Yeah, we are with you. We can see your, you and your lamps.
Yeah, I don't know if you need to see
Axios we
that
can
or
see.
if you need to just see the EUS or floor.
We will see the EUS.
Yeah, I think EUS and then.
We've got both your hands and EUS, which
Okay.
is what we want to see. We can leave the fluoro for now.
Okay. So one of the things that happens is if you wait around, things move in the small bowel. So you don't want to like delay this too much. But I think we're good here. Water pick kare na? Okay. So we're having continuous cautery going. I think I feel comfortable with this because I have a decent landing area. And the fluoro also looks favorable. So cautery. ERC वो इसकी setting है ना Axios की.
होनी पेड़ लगा हुआ है ना अच्छा वो मैं उस पे लगा
No, we try not to. So now we're gonna tent and just keep an eye on that bowel, make sure we're comfortable. And then once I have a good window, I'm gonna go for it and go through the steps. I won't be talking then, but yeah, you can talk.
Yeah, we are watching, so
Yeah.
you continue doing what you do because
Really?
you're doing. You've already explained what you want to do.
Yeah, and then Khalid bhai can actually.
so I can talk can you hear me
Yes, we can hear you.
so what he's doing is he's going to get into the best position in a way like he's looking for a long segment of small intestine in the trajectory of that stent. So just getting ready. He did already a tenting and he's not going to stop. Keep going all the way in. So this time what he did is like he's not going to spend too much time putting that opening the inner dumbbell because what happens if you take too much time it runs away from you the small intestine. So what he did is he opened that quickly and pulling back so it's into the bowel. So you can
Yes, we
see
can
that
see that, yeah.
nicely.
We can see
and
it nicely.
Now you can take your time. Now it's fine. The inner dumbbell needs to be opened a little bit more quicker. This one is going to stabilize when it's open. He's opening that into the scope. It's already open into the scope now. What he will do is he took the cautery off and now he's just going to push this.
Can we have the endoscopy view or no?
Yeah, we can. We should have an endoscopy
Can
view.
we have the endoscopy view, please?
Endoscopic view को दे दो. उनको दे दो यार. उनके
हमें देखने के लिए दे दो।
EUS की बजाय ना एंडोस्कोपी का दे दो.
EUS or endoscopic.
सर ये वाला भी उनको बोलो ये वाला भी उनको दे
यार जल्दी कर दो. We can't stay here for too long.
Can you do it or not?
ये वाला भी वहाँ जाएगा
Go ahead and release it.
Yeah, that's
we're
fine.
not going to wait for it.
एंडोस्कोपी भी बस ठीक है छोड़ दो
So you release the proximal end of the stent into the scope, and then you pull back the scope.
Yes, you have to pull back. stent is deployed, you just can't see it, unfortunately.
So can we do the endoscopic view now, please?
Can we move the room camera to endoscope, please?
या ये कैमरे
यार उस कैमरे से ही दिखा दो
इसको बड़ा कर दे.
इसको
बड़ा करो और इसको फोकस कर लो आप
इस पे फोकस कर दो good
बस ठीक है,
excellent
that's fine. Thank
yeah
you.
yeah we see that okay good
So what you like to see is now if you put in dye, so you will see the blue thing coming out. नहीं लेकिन उसमें ट्यूब बड़ी Khalid, we can't. Hello?
Take a contrast in. You put the contrast already?
We did earlier. Stent.
Hello?
Yes, can you hear me?
Yeah, we can hear you. Not very loud, but we can hear you.
Okay. We're just making sure we're in the right place. So we're going to put the wire down and inject contrast. Contrast?
Can we see the fluoroscopy, please?
फ्लोरो दिखा दें जी उन्हें.
इंजेक्ट स्टार्ट
You see the small valve?
Yes, we can see the small bowel and we can see the stent as well.
Exactly. So we're not going to necessarily balloon dilate here. Sometimes you can balloon dilate, but I'm going to leave it.
Okay.
Let it expand.
yeah I agree Mustafa I think it's in the right place there's no need to dilate and run into a risk of dislodging
Yeah.
okay
That's excellent, Mustafa.
Thank you.
Thank you so much.
Thank you. Thank you. Thank you.
काम कर दिया
हाँ जी.
क्वार्टरी काम
क्वार्टरी काम कर दिए.